Supposing a case of traumatic cataract comes to me with traumatic mydriasis. Now, in these cases, like if you to remove the cataract and put an IOL, the patient will never be happy because he will have a lot of photophobia, lot of aberrations. So he will, even if he gets 6/6 vision, he will never be happy. So in these cases, it is very important to do a SFT. Then we have now started doing glued IOLs, SFT in glued IOLs in high myopic cases. This is because we saw that when we did glued IOLs in high myopic cases, per-operatively everything looked hunky-dory. But on the other day, in some of the cases, we used to see IOL capture. So now in all the cases of high myopia in glued IOLs, we have started doing SFT. Now in Urate-Zoualia syndrome. Now what is Urate-Zoualia syndrome? The exact cause of this syndrome is not known, but in this, the pupil is, slightly dilated and there is slightly increase in the intraocular pressure. So here SFT serves two purposes. It not only brings down the size of the pupil, but as SFT, as I'll be showing you, it pulls the peripheral iris towards the center. And as a result of this, the trabecular meshwork opens up and the aqueous outflow increases and the pressure comes down. Then in patients undergoing lamellar keratoplasty, as I told you, it's almost helical flat knots. Now Dr. Priya has come up with this reverse SFT in which the knot is formed behind the iris, and that is even, I think, more useful in such cases. Now many surgeons around the world, they are doing it in cases of angle closure glaucoma. The principle is the same because you are pulling the iris from the periphery to the center. So this breaks the peripheral anterior synechia and opens the trabecular meshwork and increases the aqueous outflow and decreases the this intraocular pressure. Then last but not the least, pinhole pupilloplasty. I have not done pinhole pupilloplasty, but I think Dr. Amar has done, and he will be showing us pinhole pupilloplasty, and it is done in cases of high astigmatism like keratoconus, post-RK and post-PK. Now, which are the instruments you should have in your operation trolley before starting the procedure? You should have a 9-0 or 10-0 Prolene suture, and opening forceps, micro forceps, scissors, 26 or 30 gauge long needle, and Sinski's hook. Now I'll show you an animation so that you can understand it well. That's play button now. Okay. So now you have to make a paracentesis opening, and with the 9-0 Prolene or 10-0 Prolene, you have to pass it through the proximal end of the iris, the distal end of the iris, and you can do it by the railroad technique. And now with the help of a Sinski's hook, you have to form a loop and bring it outside the paracentesis opening. And now you have to pass the free end of the suture 4 times through the loop, like in the same direction, and then you oppose both the loose ends, and it will look something like this. Now I will show you the real-time video. Now, this was a case of traumatic cataract who came to us with, traumatic cataract with mydriasis. So after cataract extraction, we did a glued IOL in this patient. Now, if we leave the patient will get 6/6 vision, but if we leave the patient like this, the patient will have a lot of photophobia and lot of aberrations because the IOL edge is seen. So, as is shown in the animation, like you, through the paracentesis, you pass the Prolene suture, from the proximal end, from the distal end of the pupil, and with the help of the Sinskey's hook, you take it out, take the distal suture out, and this will form a loop. Now you pass the loose end of the suture through the loop in the same direction. Like if you are passing it like this, you have to pass the 4 loops like this, and if you are passing like this, you have to pass the suture through the loop in this direction only. So after passing this, you have to pull both the suture ends, and there will be a position of the iris. Now you may ask that why not three knots, or why not 5, 6 knots? This is because we have seen that when we are taking 3 loops, the knot, it tends to open up over a period of time, and if you take 5 or 6 loops, it forms a knot which is difficult to slip in. So I think 4 is the optimal. So this is how it looks after the SFT is done. You can take as many sutures as you want. And one thing I would like to tell, that I have seen many surgeons, they are making 2 paracentesis opening. There is no need to make 2 paracentesis opening. One is, I think, more than enough. You have to make 1 paracentesis opening only. Same way, in the lower part, pass the 90 prolene through the proximal end of the iris, distal end, and just with the help of the Sinskey's hook, form a loop, and again through the loop you pass the loose end of the suture in the same direction 4 times. Okay? So then again you are pulling both the sutures, and here you can see you can get a good round pupil. You can take 1 more suture if you want to give the patient the benefit of a pinhole pupil. So as I said, you can take as many sutures as you want. So this is the end of the surgery. You put the glue, seal the scleral flaps, and now this is one other case. She is a 70-year-old woman who came to us with, this choroidal coloboma, iris coloboma, and dense cataract, and she had a microphthalmic eye. So these cases are tricky actually, because there is lot of posterior pressure in these cases. So you have to use copious viscoelastic so that the rhexis doesn't run out, and you have to be careful while doing the rhexis. So after doing the rhexis, just you do the routine hydro procedures. The AC was very shallow in this case, and the anterior chamber was also not very stable. So I am doing the direct chop technique. You can do technique of your choice, and here you can see that because the anterior chamber is not very stable, I am doing it at the iris plane, not in the bag. So you chop the nucleus in as many pieces as you want. Keep chopping, because it is a hard cataract, so more the chops, easier will be to eat these pieces. So after you complete this phaco, you put a 1 piece hydrophobic IOL. Now you can leave the patient like this, but again you will see that the end of the IOL is seen. So patient will definitely have aberrations. So I plan to seal this off with the SFT. So again, here you can see it clearly, and all of you can try it. Pass it through the proximal end, again pass it through the distal end of the iris, and now with the help of a Sinskey's hook, same way, you take out the loop. after taking out now you are passing the loose end of the suture in the same direction. You see, I'm passing it in the same direction, like 4 times, 3, and this is the 4th pass. And now you pull both the ends, loose ends, and there will be opposition of the iris. So you see the pupil has become quite round and small. So, but still you can see the edge of the IOL. So we plan to take one more suture. Again, passing through the proximal end, the distal end, bringing out from the other end. With the help of a Sinski Suk, again forming a loop. So it is called a single pass 4th row, because we are passing the needle once and we are forming a loop and passing the loose end 4 times. So single pass 4th row pupilloplasty. From there the name comes. So after passing it 4 times here, now I'll pull both the ends and you'll see the gap is now covered and the edge of the IOL is not seen. So the case is now over, and you cut the ends of the suture with the micro scissors, give a wash, and this is how the patient looked post-operatively day 1. And we were very happy because the patient actually gained 6/9 vision, and we had taken the patient on guarded visual prognosis. This is because the pupil has become very small and it is giving the effect of a pinhole, and the near vision of the patient was also good because of the increased depth of focus. So that's it. That's over. Thank you for your attention. Thanks a lot. Now I would like to invite Dr. Ashwin. He needs no introduction. He's a prolific surgeon, and you can go on his YouTube and you can see crazy surgeries. And Dr. Ashwin.
Thank you, Dr. Samir, and thanks for having me on this panel. I think you can see. So I'm going to be talking a little bit about iris repair, iridodialysis repair, as well as all that you need to know in iris repair. I don't think they go separately. When you're treating an iridodialysis, you actually have to treat the iris of pupil overall. You can't do only one-sided, just treat the iridodialysis and move on. It doesn't work that way. So I'll take you through the journey of what we've been going through, at least with iris repair overall, and how from just a cosmetic procedure in 10 years back, if I remember iris repair, it was just a cosmetic procedure. If there's a pupillary defect, I will treat that cosmetically and that's about it. It has come a long way where it started to treat problems such as glaucoma, obviously in very few cases, and as well as refractive. So how it becomes a refractive procedure is, I'll take you through a small journey of this. I do have financial interest with LISR, but none of it pertains to the talk today. So the function of the iris as we know it is basically to work like the shutter of a camera. How many of you have seen a shutter of a camera? It works exactly like that. So iris functions exactly in the same way to give you crystal clear vision. That's why the iris structure is present in the eye. Different iris defects and different reasons why you get them. Obviously you can see one is, earlier back in the day, iridotomies were done very large, especially when you do ECCs and stuff. Then you have traumatic, then you have an iatrogenically caused. So the third one, if you see on the top right, is iatrogenically caused. You have another bad trauma, and I'll take you through this journey. And then you have the congenital defects such as the colobomas and stuff. So these are some of the reasons. Obviously there are multiple more which you'll see in your clinics. Why we are starting to do a lot more iris repair in today's world, because the number of cataract surgeries have gone up, the number of iatrogenically caused this thing, the shaffing, the phaco machines, so much has increased our need to do a iris repair. If you look, some of the some of the reasons why we are doing them is also it obviously lowers intraocular pressure, and we'll talk about that a little bit, not too much. But main reason is to compartmentalize the eye. So if you look at the one structure that actually compartmentalizes the anterior segment and the posterior, anterior chamber and the posterior chamber, it is the iris structure. And we are trying to recreate that structure in these scenarios. That's the basic reason what we're trying to do. We're trying to also open up the angle. If you look at the angle is what we're trying to also open up in these cases. You look at a Urid Zavalia, you look at a peripheral anterior synechia, what's happening there? The iris structure is getting attached to the angle. And if you mechanically open it and keep it structured open, if you just pull it and you leave it, it always goes back, because that's the tendency of the iris, that's the tendency of the avascular angle, and it goes back into forming a raw area, always goes in fibrosis. So that's something that you mechanically are trying to prevent from happening. Can we do that? Yes, with pupilloplasty or iris repair. So just understand the concept as to why we are starting to talk a lot more about iris repair, iridodialysis, pupilloplasty. All of these go in hand. They can't be separated from one another. So you have to know, if you want to go in the OR as a cataract surgeon also, you want to be able to do these iris repairs, because that's when you really take the level to the next level. From a glaucoma perspective, from a refractive perspective, you do prevent all the halos, glare, all of those issues by just doing a simple pupil repair or an iridodialysis repair. One of the simple basic things is, if you do a secondary IOL, whether you're doing a Yamane, whether you're doing an iris claw or a glued IOL, anyone, whichever you're doing, you do not have an anterior capsular rim. Remember this, the anterior capsular rim is the anterior capsule when you do a rhexis. That rim prevents the optic from coming above. So if you don't have that, in secondary IOL specifically, you do not have that anterior capsule. What do you see in these scenarios is this. You get an optic capture. You get this optic capture which the iris will go behind and lift the IOL up, it will tilt the whole IOL. You will have an astigmatism which you didn't know why it came in. But the reason it's coming in because you do not have an anterior capsular rim. So the first thing I do in these cases is test it out on the table. If I'm having an optic capture on table, that means I can guarantee and tell you this patient is going to go into a dark space, it's going to be dilated. When it comes back, it will go behind the iris and lift the IOL. Just do a single pass 4th row. On these cases, you prevent this issue from happening ever. You stabilize the IOL in one position instead of it tilting in that angle and causing a lot of refractive error. So the refraction is why I'm doing this. It's not because cosmetically it's going to affect me in nothing. It has nothing to do with cosmetic. It's everything to do with the refraction. That tilt causes astigmatism. I can prevent it. That's what I'm trying to say with optic capture if you are having a secondary IOL specifically. So ask the patient a lot more, investigate when you have a clinical finding of optic capture. Why this is happening is because there's no anterior capsular rim, which was the one thing that was preventing the optic from popping up. So apart from that, when you have endothelial keratoplasty cases, the one thing that we start to do is you put air bubble. You put air bubble because you want to hold that graft in place. When you're doing an endothelial keratoplasty, you have to hold that graft in place with the help of an air bubble. The only bandage you can put on a fractured hand is that sling. The air bubble is the sling to that graft. What we're trying to do is, if you don't do a single pass 4th row or any pupilloplasty of your choice, if you don't do that, what happens is that air bubble starts to go down into the posterior segment, because in these cases, you don't have a bag. Specifically if you have, cases where you have a secondary IOL, or these are very complex cases. These are not the normal cases where you have a very nice Fuchs dystrophy, which they show in the academy and all that stuff. These are very easy cases, but in tougher cases, you have to do a pupilloplasty, make that pupil round, support it with a nice IOL in place. Now that's the foundation for your air bubble to hold the graft in place. These are some small conceptual changes that we have gone through with learning with a lot of hardship. Honestly, we learned with a lot of hardship to come to this realization that if you place an intraocular lens and a pupilloplasty to make that pupil sort of round, even if not perfectly round, sort of round, you're able to hold that air bubble in place, and it will tamponate that graft, hold that graft in place for the next couple of weeks, which is when the recovery happens for that patient from an endothelial standpoint. I'll just take you through a case where we did a PDEC with a single pass fourth row. So if you see this case, usually such a bad cornea, ideally people would usually just do a PK and go ahead with it. But we have stopped doing that in at least 80% of cases. We've stopped doing penetrating keratoplasty, actually speaking, a lot. And DMEC or PDEC, I'll leave that choice to you guys, but what we do is PDEC because we found that the rebubbling rate and the stuff is far superior. It's much better. We have lesser rebubbling. The graft is thicker. It's stronger in many ways. So what we're doing is a single pass fourth row here because that pupil is too large. If I start putting an air bubble there, it will start going down. The air bubble will start passing down. And what I'm trying to do here is now closing all the sides so that there is no gap left. Even from a refractive standpoint, it's a far superior procedure to do. End result I will show you at the end of this case. So this is just a PDEC which we're doing now, which the ideal scenario in these situations is we do a pneumatic dissection of this thing. Ideally people try to do it in the saline BSS, but we have started to move into pneumatic dissection of the desmids, which clearly shows me the angles or the margins of this graft of the desmetorexis, which I'm trying to do here. What I'm also trying to use at different points of time over here is an endoilluminator, and you'll see this coming in and out. So that gives me the proper visualization in these really challenging cases. So I've done my single pass fourth row. All these cases require a different mentality because you have to go from foundation, bottom to up. So if you first treat the iris, then you're treating the graft. You're not treating the graft first and then the iris. It doesn't work that way. So always remember that. And if I had an IOL issue, I would have treated the IOL first. So the IOL, iris, then cornea. So this is my graft going in, and just in interest of time, I'm going to, because this is a iridodialysis lecture, I'm not going to show you the graft, but this is basically what the graft looks like towards the end. And once the graft is in place and my sutures are in place, I've basically closed up the case, and you can see the pupil is pretty good and round. And here's where it looks pre-op and post-op 15 days out. No sutures, no PKs, nothing of that sort. The same case looks much better with just doing instead of doing a penetrating keratoplasty, you're doing a endothelial graft. Again, another case, a difficult one. I'm not going to show this just in interest of time. I'll move on to the iridodialysis, where you have some novel approaches and different approaches to treat the iridodialysis. So you see this patient, a 65-year-old bad trauma, comes to me with a really bad thing, and this is the real-time scenario, guys. This is where you actually have to use iridodialysis, pupilloplasty, all the things that we have learned on the same case. So what I'm showing here is a very bad trauma, and you can see here I have done a posterior trocar for infusion because it's a soft eyeball, it's a traumatic case. So I have to first do my anterior vitrectomy, and you can see the iris is pretty bad, but it's all admixed with a lot of vitreous. So what I'm trying to do is first iron out this iris and see what the hell is going on inside. Once I start to realize that this whole iris actually from the inferior has come superiorly. So this was a small incision surgery that was done. While they had beveled that whole nucleus and tried to pull it out, they've also pulled out the iris. So the whole inferior iris is on the superior side. So what I'm doing is first place an iris hook, do my anterior vitrectomy, do my glued IOL. So the foundation is laid from a lens procedure standpoint. Once I'm done with that, I'm now moving on to removing any of the bag remnants if there are any of that sort, and now moving to starting to visualize what the hell is happening with the iris. So you remember the iris was fully pulled. There's also a tear at the root. There's a tear at the root. So I'm first doing a single pass fourth row at the root of the iris inferiorly. The root of the iris now has a single pass fourth row. I have now placed a trocar assisted iridodialysis. So trocar helps me pivot because it's a 180-degree iridodialysis. I can't keep going in. One of the biggest irritations that a iris repair surgeon has is that when I am passing those two double arm needles through the corneal lamella, it will somehow it will catch the corneal lamina and I have to abort the whole procedure. I know it's a little more confusing if you have not done it. I'm happy to talk to you about it on the side, but the trocar really assists because you have a metal lumen, not a corneal lamellar, which you can get captured with. So a metal lumen, when you pass those two double arm, it's easy to go in. There is no way that it is going to capture any corneal lamellar tissue when that needle passes through this thing. It's a very small point, but it's a very annoying point when you come down to it. It's like that small angle change that you can make. But we'll talk about it offline. But what the idea is to use the trocar, pivot between left and right. If you want 3 passes, you can do 3 times. If you want 2, you can do twice. I did twice in this case. Now once I've done, so remember I did a single pass 4th row at the root, then I did 2 iridodialysis using the hang back technique, and now I'm redoing a single pass 4th row at the pupillary zone to bring the pupil down to size. So it's a 3-prong approach: single pass 4th row, iridodialysis, back to single pass 4th row to make the pupil somewhat round. It probably may not be as the God has given us, but to come to somewhere close to where we were, you can use 2 approaches for the iridodialysis repair. One is the flap and one is the scleral ridge. But end of the case, it looks pretty decent from where we started off, where the whole iris was come ahead. And this is how the patient looks post-operatively in these difficult scenarios. Another small technique is the sewing machine technique. It's a very nice technique by Dr. Ravi from Bangalore, I think. And he kind of invented this procedure. I kind of liked it, so I kind of incorporated it in certain cases, especially when the nose bridge does not come in the way. You can use this technique. It really works very well. So the idea here is, this is a patient which was an iatrogenically caused. The phaco probe from that incision side was pushed in and it had caused an iridodialysis. It happens a lot to all of us. I'm not saying it's uncommon. And how do you treat it? So I've started using a new site, and just in interest of time, I'm not going to show you guys the part of the phaco, but the idea here is, I've made a paracentesis 180 degrees away. I've seen the iridodialysis on that side. Now I'm passing a ninoproline suture through a 26 gauge needle. Ninoproline suture through a 26 gauge needle all the way. So the needle and the proline suture is all I have. I don't have the this thing. So this needle, this 26 gauge needle acts like the sewing machine needle. All I'm doing is passing it through, coming back into the anterior chamber, passing it through again through the iris and the ridge. So it causes all I'm doing is just like a sewing machine. Have you ever seen a sewing machine work? Exactly on the same principle, using the iris tissue to attach to the sclera. And this, I just chop in the middle of those loops. I attach 1 to 2, 3 to 4. So this becomes my iris repair, iridodialysis repair. This is only used for iridodialysis. You can't use this for pupilloplasty. You can use this for iridodialysis because you need the scleral ridge or the sclera to attach it to. That's the advantage of using it. It's fast, it's quick, you don't have to keep coming out, you don't have to keep going in. It's all like a sewing machine, you use it. The only issue that I would say which comes is the nose bridge. So if you have an area of the nose bridge, then you'll have to pivot to another technique, which is the hang back technique, which I'll show you next. This is where I'll show you the hang back technique. I did show it in the other case, but this is another case. This is a patient from Iraq who had come with a very bad knife injury, and lens was out, everything was out, and the iris was attached after a month of this thing into the cornea. And so what I'm doing here is again laying the foundation with an intraocular lens procedure first. So once I've done with the intraocular lens using the glue dial technique, I find that much better from a titration standpoint, from a centration standpoint. I can center the IOL much better with a glue dial procedure. So once I've done with that, now I'm starting to do the iris repair. So guys, again, I have to start applying my mind every time I'm doing this. I need to know whether I'm going to use a pupilloplasty or I'm going to use an iridodialysis. In this case, I used an iridodialysis first. Remember the last case, I needed to do a single pass 4th row first. Here I'm doing a iridodialysis repair using the hang back technique. Double arm needle going through the cornea, through the iris and the sclera, tie it outside through the ridge. Second, again doing a iridodialysis repair with the hang-back technique on the other side to anchor that. Now I'm trying to anchor that space. This is a little risky because of the fact that the gap is too large. Can I manage? Will I be able to manage with this atrophic iris? I don't know, but I tried and it did work. The second one, will it work? I don't think many of us would have actually tried this out in our ORs, but I think I did try it out. Even though there was a big gaping wound in that iris over there, I still went ahead and tried it, managed to succeed somehow in this scenario, but it can happen that it can snap. It can cheese wire, it can snap, anything can happen. Be ready for that. And if it does happen, then don't try it again. This is the 1 week post-op of the same patient, 3 weeks post-op of the same patient. It looks pretty decent from where we started off from that knifing injury. So you just have to have a little courage in these patients to go ahead. Last technique which I think is extremely beneficial for people to know is I would say the double flange technique. I don't think it's called the Yamane technique. It's not him who discovered this, but the idea here of the iridodialysis repair is to go ahead with a 26 gauge needle or 30 gauge needle, pass a 6-0-proline suture, flange it on one side. That flange becomes your point of pivot for the iris to come back, to pull the iris back. And then you flange the other side as well, not too tight because then it cheese wires through. Make it a little loose. You don't really need a fixation point of that strong, but it's very simple. It's 2 flanges on either sides and you move ahead. You go ahead, you don't have to think too much. Obviously again a little bit over here is the angle of the nose, so you just be careful of that nose bridge whenever you're doing this technique because you need the needle to come from the other side. The needle to come from the other side is quite a little tricky, challenging situation to be with. I don't think I have time for this one, but okay, so in that case I'll just show you this is a very bad trauma. This is a uveal prolapse, an iridodialysis, lens is gone. With the primary procedure with the uveal prolapse, all that came out in the beginning itself. And what I'm doing here is first an exploration. I have no clue what the wound looks like. I don't know what is happening. There's a soft eyeball, so first place a trocar AC maintainer. If you can't place a trocar posterior maintainer, please place a AC maintainer because you can easily visualize it. You don't have to go in the choroidal space. What I'm doing is now first examining, excising this iris. I don't need this iris. It's been more than 6 days old. Not going to keep that iris tissue. Clear up that the iris and vitreous in that space. Make sure that the wound is closed with proper interrupting sutures. And now I'm placing a trocar in that spine. Also doing I'm also doing a oblique placement of my flaps because I cannot place a horizontal flaps in this case. The wound is too large. I'm making my sclerotomies 1 millimeter behind the limbus under the flaps. I'm using an iris hook to kind of hold that iris behind. Now I'm going behind the eye. I'm using the second port as my sclerotomy becomes the second port for the pars plana approach. That's just a light pipe, so I don't really need a separate trocar in that scenario. What I'm doing here is a full vitreous hemorrhage. I'm trying to remove that vitreous hemorrhage with doing a PVD induction and ensuring that there is no vitreous at the end of this or vitheme at the end of this case. And you can see here I've cleared up the retina. Retina looks pretty good, decent for me to move ahead. I've got a good red glow now. Moving ahead with now treating the lens first. So again, conceptual change here is foundation upwards. Do the treatment of the vitreous, treatment of the IOL, treatment of the iris, and then if you have corneal issues, you can treat that as well. But that's all can happen in one go. You don't really need to split this in stage 1 to 4. You can do it in one go, but it has to be done in this conceptual manner from bottom up. So the idea here is now I've placed my intraocular lens using the glue dial technique. Again, I can tighten this to the centration of my choice. If I need to bring it to the side, left, right, I can do that. Obviously with relatively has to be centered as much as possible. Now I'm tucking my haptics using the Gebauer-Charriot's tunnel. And now coming to the pivoting of this iridodialysis repair, I'm using the flaps, using the root of the iris and the flap, using a double prong, double arm needle to kind of use the hang back technique and anchor this iris to the sclera. Once I've done with that, I'm still seeing a large optic edge. So now do a single pass fourth row at the edge of that pupil. Don't try and do too large gaps. It's not possible to cover that gap. So try and see as less as possible. Smaller gaps, try and close them out. I still have this big gaping wound here. And remember, I did not have uveal tissue. I had excised my uveal tissue here. My iris is out. I would not try this again, but I'm going to show you why I did try it, because it's something that I probably made a mistake here, and I think it's important to know what mistake I made. I'm trying to pull, but without visualizing what I'm causing on the side there. I'm causing my own iridodialysis, iatrogenically caused. This was not there before. So this is iatrogenically caused. This can happen. Don't worry. Abort, come out, and leave it. One is leave it. I thought I'll leave it. But then it started to flap. And I said, you guys are going to judge me saying that bad surgeon doesn't know what he's doing. And the patient will not be able to see next day. So I had to anchor this down to the sclera at some point. Otherwise that flap of that iris would come right in my pupillary zone and it would not be looking good. So did anchor it by placing it a little more superiorly so that it's easier, also covers the edge of that optic. Patient did do well visually 2 months post-op because it was a larger case, longer case, had vitreous hemorrhage and all that stuff. Did improve to 20/30 or 6/9 vision. And I want to stop with this. These are some of the complications that you can prevent and avoid by just doing a pupil repair or an iris repair or iridodialysis repair. Thank you very much, guys, for this.
Thank you, Dr. They were really amazing and really mind-boggling and very difficult cases. Somehow he made it look very simple. So, any questions?
Thank you. Yeah, happy to take a question or two. I can take it offline also. We have 2 more talks to go. Thank you very much.
Okay, so now I'd like to invite Dr. Priya, and she'll be speaking on reverse for SFP and many other more amazing videos she will be going to show us.
Good morning, everybody. It's a pleasure to be here in front of all of you, and I'll try to make things simple, so that it can be easily emulated in the OR. To go ahead with the first thing is basically the iris repair procedures are divided. I consider them to be a pupil-centric or the iris-based repair. So these are the 2 ways that I usually divide the iris repair procedures that we need to adopt to perform in our ORs. Iridodialysis repair, when we fix up the iris base, many times what happens is we get withdrawal of the pupil on that side because there is correctopia, because maybe you have taken too much of iris tissue in the needle. So many times you have to combine it with a pupil-centric method. That is, either you do a single pass or a modified Sheepsers or a MAC canal or whatever you are comfortable with. So many times it happens that we need a combination of the surgical procedures to be adopted to achieve a good centric pupil central method. So going ahead with this, I'm just showing a very simple case. This is the first case that I'm trying to show you. This is a referred case. The surgeon had performed phacoemulsification, and there was a chafing out there because probably it got embedded into the phacoemulsification probe, and this is how it happened. The patient had a lot of photophobia. So this is a very simple thing to do here, is to do a single pass 4-throw PUPILLOPLASTY procedure. But before I start saying this, you need to analyze the margins of that hole. There is a lot of loss of thickness of the iris tissue there, and there's a lot of chafing. So if you pass your needle through that area, it is going to give way during the surgical procedure. So you need to avoid that area and take the healthy amount of iris tissue. Now, another flip point of this is that if you take too much of iris tissue, then you might even cause a lot of compression of the iris coming up from all the sides. So you need a perfect calibration how to go ahead with that. Having done this surgical procedure, coming up to the basics of single pass, we passed. You can take a 9-0 or a 10-0 polypropylene suture. It's a long suture. It's a long needle with a suture which is available in the market. You need that to perform this pupilloplasty procedure. So that is what is available in our country as of now. Now, when we go through the proximal and the distal portion of the iris tissue, when we take up through that and you withdraw the loop till that point of time, it is similar to a modified steep surge. But the difference that happens in a single pass is that you do not have to take the pass again, because usually we take sutures like you take a 3 throw, then you take 1 throw. That is what we consider to be a knot. But that's not the case with a single pass. Now, picking up this position, the loop has been withdrawn, and the suture end, you can cut off this needle, but I don't want to sacrifice my suture at this point of time, because I know that with this single suture I will be able to close down all the iris defect that is present there. So I'm not chopping off the needle from there. I'm still keeping it, but I'm trying to pass that needle through the loop 4 times. When it passes through the loop 4 times, you just pull both the suture ends, it beautifully glides inside and it approximates the iris tissue, provided you have not embedded corneal lamellar fibers into your needle. So that is a very crucial point, and that is, I think, what Dr. Ashwin was trying to highlight in his procedure. So yeah, this is a very technical point. When you pass the needle through the paracentesis, no corneal tissue fiber should come up to it. So you keep on doing this single pass 4 throw till you close the entire iris defect. So this is a simple thing. I move on to the next thing. That is a twofold technique which now I'm trying to show you, which we published in the Journal of Cataract and Refractive Surgery. It is a non-appositional repair with a pupilloplasty procedure. So this is just an animation that describes the procedure. So this is an iridodialysis repair that is going on. This is a traditional non-appositional repair described by Dr. Snyder. What you need here is a double arm suture, and you fix up the iris base, and as I said before, whenever you do that, many times you have that withdrawal of the pupil coming up on the side where you have done a repair. So whenever you get that, you need to close it, because otherwise you have an eccentric pupil in the postoperative period. To avoid that, we usually combine it with the pupil-centric method, whichever method you are doing. Here I am doing a single pass, so you close down that defect, and then it looks cosmetically as well as functionally good. That's the most important aspect of doing a pupil repair. So these are some of the crazy cases, that we take up during the surgical procedure. Having done the basics, we can go ahead further. This was a case, and this was a traumatic cataract with a very massive severe iridodialysis. I'm going to show you a recent case that I did with one of the most recent methods that we have adopted. Now this is a traumatic, again a referred case, a traumatic cataract. This is the trocar anterior chamber maintainer. I'm using this for fluid infusion inside the eye. I have put triamcinolone also to detect if there is any vitreous inside, because this patient was a pseudophakic patient, but somewhere down the line I did feel that maybe there might be some vitreous tricking in, but fortunately it was not there. So what I decided was that, okay, now I just have to do a pupil repair procedure for this patient. So we have done a peritomy, and this is the scleral groove that is made along the entire length of the iridodialysis repair that we actually want to do. And now I am trying to flatten up the iris tissue. That is very important that we need to do, because it's just curled up. So you need to flatten it out to see that how much iris tissue is available and how much you are going to take up into your needle to fix it to the sclera. So this is the trocar assisted iridodialysis repair. I have removed the fluid infusion now. Instead, I am using a viscoelastic now, and I am using that trocar which was placed to pass my double arm suture for an iridodialysis repair, because this takes away my headache of accidentally getting those corneal fibers into my needle, and I don't want it, because then I will have to redo it because the suture is not going to slide inside. So this is the trocar assisted repair. The double arm suture, now what you can see is flipping inside, and moment you pull it from both the sides, you have that iris tissue coming up to the base. But yes, again, when you take up the sutures, again you need to do a bit of calibration, trying to oppose it to the sclera, but not pulling it too much also. But still, in spite of doing these things many times, we still have that correctopia kind of a thing coming up. So as explained before, the trocar, you can pivot it almost like it gives you an SS of about maybe 100-120 degrees of iridodialysis. You can easily correct with placement of one trocar. out there. So this is again the same procedure being done. You keep on doing it till you are done with the iridodialysis. Maybe you might need to do it once or twice or thrice. It all depends upon the degree of the iridodialysis that you actually have. The only point that I want to say is that, you need to get those sutures into the groove. That is where you are going to bury it. Well, now I had coupled this procedure with a reverse fourth-row pupilloplasty, which I will showcase in my next animation, that how we do this procedure. This is exactly the reverse of a single pass fourth row. The needle, it enters the iris tissue from behind and it comes up anteriorly from both the sides. So your suture track is like that. So only thing that makes a difference here is that in the post-operative period, you do not see those suture knots on the anterior surface of the iris. You actually do not see, it's like a plastic surgery that you have done for your patient. There are no sutures to be seen. Actually, many times even if you see these patients in the post-op period, if nobody tells you, you will not even come to know that pupil repair has been done for this patient. So it works beautifully like that. The knot goes behind the iris tissue. Otherwise, the entire surgical procedure is the same as a single pass. But yes, it's a bit technical challenging because you need to pass the needle from behind. So you need to be a bit more of an ambidextrous, and you need to have a little bit of flexible iris tissue out there to do the procedure. So anyway, this is what I was trying to highlight. You need to bury those knots into the scleral groove, and you need to rotate them as we do it with the corneal sutures, and then you can just seal off the peritomy with whatever. If you have a glue, you don't have a glue, it's fine. We can just do a cautery and you are just almost done with that. So this was about that. Application, Urette-Zavalia syndrome, a persistently dilated pupil. I think many of us, not very often, but yes, occasionally we do come across. You have done a perfect surgery and you come out of the OR, but the next day you see your patient has a persistent dilated pupil for no reason, does not respond to miotics. That's a Urette-Zavalia syndrome. The pupil remains into that position forever. And I had this patient because the surgeon had done a very beautiful surgery for that, and it was a premium IOL, but patient was not happy because there was so much of glare. I'll show up that video. What actually happens is there, you can see it. It has been reported after phacoemulsification, after penetrating keratoplasties, after DALC procedures, many times even after YAG also. The pupil goes into a dilated phase. It causes peripheral anterior synechia with a raised intraocular pressure. And what solves it is a pupil repair, because what you have to do, you just have to bring the iris into the center. But it has to be done as a timely procedure, not when everything is scarred in the periphery and then you have nothing left with you. It won't work then. So the timely intervention is very important. In case if you have a patient like this, what I'm trying to show you now, please understand it's a Urette-Zavalia syndrome, and no amount of pilocarpine is going to work for this patient because the pupil is not going to respond. Now this was a premium IOL patient which was referred to me. This was a lady. She was constantly complaining. She had raised intraocular pressure around 40, 45. Nothing was working for her. So I took her up surgery. Maybe it was about 1.5 months after the original surgery that had been done by the surgeon. And what I'm trying to do now was I was trying to assess the flexibility of the iris tissue, because the iris tissue has remained like that for maybe 1.5 months like that. So we need to just see how much flexible it is, and then we need to gauge how much amount of the iris tissue we are going to take up into the suture needle. So this was a case where I am doing a single pass fourth row pupilloplasty procedure for this patient. As previously explained, you have to take 4 throws going all along in a single direction, and if you forget to count, you can take 1 or 2 throws extra. Nothing matters if it is 5 or 6 throws, but it should not be less than 4. If it is less than 4, it is going to open up. When you slide, it will go inside, and when you will cut up, it will just open up. So in order to avoid that, you have to take an optimal 4 throws. If it's more than that, makes no difference. It just adds to the bulk of the suture inside, but then it's safe. So this is single pass, which I'm trying to do on the other side too. We have actually developed a nomogram for this, like, depending upon the type of the peripheral anterior synechias, the amount of synechias that you have in the periphery, you might have to do it even thrice. That's a 6-point traction. But this patient, it was a fresh case, so I just decided that, okay, I'm just going to close down the pupil from 2 sides. And actually this patient responded very well in the post-operative period. There was nothing else that I had to do for this case. Immediately the intraocular pressure went off. I did not give steroids to this patient. Post-operatively, it was on the non-steroidal anti-inflammatory drugs that I had kept the patient, but she responded very well. So, but the point is that, we need to diagnose this, that, okay, this is Urate Zavalia. This may be. You can wait and watch with your treatment, but if it doesn't work, you should consider doing this procedure. So, this is how you just go in and you take up a micro scissors and you cut up the suture from both the sides. But when you cut up the sutures, these are some of the finer nuances of this surgical procedure. When you are cutting up the sutures, you have to be very careful, and you just pull this. Many times we feel we have cut the suture, it has not cut, and it has happened to me also. I just pulled it off like this, and what happened was, in a hurry, I created an iododialysis because I thought I have cut the suture and I pulled it and it was not cut. So I just pulled it and it went off. So then I had to do an additional iododialysis, not for this case, for another case, but yes, it can happen. So you have to be very careful when you're just even taking off those small sutures from both the sides. The other applications that have been described for the single pass is for the endothelial keratoplasty procedures, as it was previously explained by Dr. Ashwin. I'm not going much more into detail because you do not have those actual knots coming up into the anterior chamber. It almost lies flat. It helps in compartmentalization. What I actually want to show you is the reverse fourth row technique, which recently I had described last year in the European Journal, and how we go about it. Now this is the animation that describes the passage of the suture in a reverse fourth row. This is exactly the opposite of what you have been seeing in the single pass fourth row. Look at the way the needle is piercing the iris tissue. The needle pierces the iris tissue from the posterior to the anterior surface. And then you railroad this. So now your suture track, I will show you in the next animation how it is actually going inside the eye. So the only difference is the way your needle pierces the iris tissue. So that makes all the difference while doing this surgical procedure. So you will draw the loop outside the suture and is cut 4 throws. You go in, and when you cut it with a micro scissors, the knot goes behind. So this is the suture track. It's like doing a plastic surgery for your patient if you do this surgical procedure. This is the suture track. So when you are tying those 2 sutures, by pulling them, it goes behind. So, well, this is the clinical video. If you want to see this, I'm just highlighting how to pass on the suture. From one of the paracentesis incision, the 9-0 suture needle comes in, you hold it with an end opening forceps. You will need an end opening forceps here to hold it because the needle automatically doesn't go inside. So you have to hold it, and then you have to pass the needle from behind. So this needle goes in there. Similarly, from the opposite side, you come in with a 26 gauge needle, again the same way, goes behind, comes in front, you railroad both together, and then actually, honestly speaking, single pass is more easy to do than this surgical procedure, because single pass, you can just pass on like this, it goes with your movement. So that's fast and brisk, but this also works like if you really want to, you are in an advanced stage of iris repair, you can pick up the surgical procedure too. So this is like the suture thread has totally passed on, and then you're just withdrawing the suture loop. You can use a Sinski's hook or something, and you can pull up the suture thread outside. This is the loop that we call, and you have to pull up from the opposite side. It comes out through the paracentesis incision, and then comes the 4 throws. I'm going slow on this because if anybody is trying to learn, they can just pick up some learning points from here. Because for me, there is no point rushing if nobody even picks up what I'm talking about. So these are the 4 throws. You can watch them gradually going on in the same direction. 1, 2, 3, 4. You can count it loudly also. and then you just pull, it automatically slides. See, this is where comes the importance of not having a corneal fiber. Then only your suture will slide. If your needle had a corneal fiber, it will not slide. It will remain on one side. On one side it will go inside, and on one side it will not go inside. And if you pull it too much, instead of sliding inside, it will cause an iridodialysis on the opposite side. So be very careful with that. So this is the reverse knot, which just goes behind. You won't see anything in the anterior chamber. This is the anterior segment OCT, shows nothing. You will not be able to find it out even on an anterior segment OCT. So this is the suture knot that was for the SFT, but for the RFT, reverse fourth row, it goes back like that. So these are some of the cases, with RFT. That is what I said. It's like doing a plastic surgery. I have put up an arrow where the suture has been taken. In fact, Samir only saw my patient in the post-op and he said, "You didn't do any pupilloplasty. I'm not seeing any suture." I said, "No, I did a pupilloplasty." Even he could not make out on the slit lamp that, okay, the repair has been done. So this is, I don't know if I have time.
Yeah.
No, I think so.
You can
I'll just wind up this
Well,
fast.
yeah,
This is a flanged riveting technique. I'll just show the animation for this. This is one way of doing an iridodialysis repair. You can take a 6O proline suture, create a bulb with a low temperature cautery, and this is a 30 gauge needle which is passed, and you can railroad that into that. You can pull it like this, as you see, cut off the extra suture and create a flange out there. The flanges should be big enough to hold the iris tissue. So this is a flanged riveting technique which was originally described by Japanese doctors. So this is how it actually works. If you do not have a low temp cautery, it is fine. Even if you have those ballpoint cauteries, they work very well. You can just heat them up and you can use them to create a flange. It works beautifully. So this is just a case. I'll just run through this to show you just a clinical case. Along the iridodialysis, the first thing is you do a peritomy, create a groove. If you don't want a groove, it's okay, fine, but you will have to create a Hoffman pocket because you need to have something to bury those sutures. You cannot leave those sutures just like that in the beneath the conjunctiva. So these are two options that you have here. It is associated with a traumatic cataract. So first the cataract extraction is to be done. Once you are done with that, then you go ahead with the iris repair. This is a small iridodialysis, so no iris hooks were used, but if it's a big, you need to use the hooks also to withdraw the iris tissue from that area because you need to do phaco first. Anyway, this is 6O suture, proline, flange is being created. You can just see this, and then we just press this so that the flange becomes flat and it becomes much more wider, and so that it holds good amount of iris tissue along with that. So what is being done is through the scleral groove, you pass a 30 gauge needle, and from the paracentesis incision, you just take that 6O proline, you glide into the lumen, and it works beautifully. So you need to, you can keep the anterior chamber stable all the time. Here there is no complication. You can very easily use an OVDs inside to have a deep anterior chamber. So you are just threading this suture into this needle. Nothing much is to be done. You just have to pull this out, and then you create a flange on this side. The only downside of this technique which I have found is that if your iris tissue is very friable, the flanges don't hold the iris onto its base. The flanges, they just give way many times. But if the iris tissue is healthy, it works brilliantly. So it needs a good amount of healthy iris tissue to be there. If it's a friable kind of a thing, flanges are not going to work. They're just going to get out of it. So this is just like you are just approximating even the area next to it. You are imbibing it. Yeah. See, this is very important step. The amount of iris that, I always keep on saying this, whenever you are taking the iris tissue into the needle, you should know how much iris tissue you are taking into the needle, because the amount you take that is the amount that is going to be withdrawn. If it is too minimal, it gives way. If it is too much, it causes too much of correctopia. But it's very difficult to find out the exact balance of the amount that you actually need. But anyway, you need to know both the methods of doing a iris repair. That is, you need to know even an iridodialysis, and you even need to know the pupil centric. Yeah. So you just create a flange, you cut this off, create a flange on this side, and it holds it beautifully into this position. Thank you so much.
Thank you, Dr. Priya, for the wonderful and amazing videos. Now I would like to invite Dr. Amar Agarwal. Dr. Amar Agarwal is our mentor, and best for the, we have kept the best for the last. So, Dr.
ये भी लगा लो.
Let us see what he is going to show us now.
नहीं खुला हुआ है. क्या हुआ? लगा लो. Yeah, okay. So, good morning everyone. Nice to see a hall like this at 8:30 in the morning. It shows people are interested so much in iris repair. So let's look at this case, okay? Toric multifocal IOL. This was a VIP patient. Obviously, patient has had LASIK done before, went in for a toric multifocal IOL, went in for a refractive surprise. The surgeon then called me up and said, I'm having a problem, what do I do? Now understand, these patients are very fussy patients. Obviously, they want to be without glasses. So when I examined the patient, this was how the pentacam looked like, and I'll come to that more in detail. Important when you see pentacam, people look only at the astigmatism. Please look at the RMS HOA, higher order aberration. Look at that, it's 1.1. A normal person, please understand, will be 0.3. So, I know this is a problem here. There are higher order aberrations here. LASIK was done 15 years back. My first problem was, there is not only an astigmatic problem, there is a spherical mistake also has happened. So I thought, listen, I have only one chance. This patient cannot go back again, come back again for surgery. Let me do an IOL exchange. So here you see I'm explanted the lens by putting it in the anterior chamber. I'm putting an IOL scaffold. So the lens which I'm going to replace it with, I put it inside. Now I'm very safe to cut the first IOL. Because my IOL is already there behind, I will not rupture the posterior capsule, and we published this in the JCRS previously. Anyway, coming back to this case, now what have I done now? I have solved my issue of spherical. But please understand, I have an astigmatic problem. My second problem is, remember this patient had a multifocal IOL. That means he is very clear, he needs to see distance and near without glasses post-operatively. Now I put a monofocal for him, Virendra. I have not put a multifocal for him because I do not know, again I will have some higher order aberrations coming in my hand. So now what I am doing is I am doing the PUPILLOPLASTY. So take a straight needle, this simple goes inside, everybody has talked on it. Take a Proline needle, 9010 through cornea. From the other side, paracentesis. Paracentesis you need only on one side, 26 or 30 gauge, railroad the two. Once you do that, bring it out. Now remember the number 4. Pass it 4 times, and that is game, set and match. So you just pull. See, normally you do 3, 2, 2 or something like that. Every time you go in and pull out, you have a chance of hitting iris, chance of hitting IOL, chance of hitting endothelium. Here is just once, 4 times remember. Now see, I am passing it from one end through the clear cornea. Now, from the other end, I will now take this 26 or 30 gauge needle through the paracentesis, and the principle what I am doing is, we are going to make the pupil small. Once I made it pupil small, the peripheral rays get blocked. When the peripheral rays get blocked, the rays of light will go only through the center. Now look at this device which we have created called the holiday pinhole device. So understand one thing, when we started this procedure, I knew my knowledge on optics, I am telling you, is underground. Underground means deep down to the earth. I am that bad. So I knew I'll be in trouble. So I called up one man who is a guru of all, Jack Holiday. I told him straight, Jack, this is my concept, I'm doing this, but I tell you honestly, there is no way I'll take it to another level. And I'm not joking, since then till today, he is with us every time. So with him we designed this holiday pinhole device. So simple device is from epsilon, I have no finite. Put it in front of the patient. Quresh, you have a patient who has astigmatism, put it in front of the patient. Ask him, does he like 0.5, 1, 1.5, 2? Whatever pupil he likes, make it. Understand all of you? Very simple device. Second thing, remember, if you see our latest issue with Priya and all we have done, and Jack Holiday, and I have to give full credit to Priya on all this peer review work and the SFT and the RFT which he has brought out also. But simple thing is, previously, I'll tell you honestly, I'm talking to you from heart right now, I used to always make pupils 1.5. And they are very good. I'm not joking. But then after some time, I started seeing these patients post-operatively. I started asking myself, can I make them better? They'll be 6'12", very good. I'm very happy. From counting finger 1 meter to 6'12", the patient is jumping. Can I make him 6'6"? Then I began to understand, if you have higher order aberrations higher, the pupil will have to come smaller. Matlab, I said normal is 0.3. So let's say he has a 3 HOA. I'll make 1.5. And I've checked this in our peer review paper, we have checked this. Basically, it'll happen. Let's say he has a 13 HOA, highest. He will go to 1 millimeter pupil. And you can check with him. He asks for 1 millimeter, automatically bolega, bhai, give me this, I like this. So automatically make the pupil 1 millimeter pupil. So let's make this short because we don't have time now. I'm making this smaller and smaller. Now one more trick I tell all of you, okay, which we started now and I'll just show it to you soon. Look at the endelevator from outside. The key issue is one size. You have to be bang on track. But the second biggest issue is the location. Your Purkinje image P1 has to be bang centered. Okay? So look, always keep a vitrectomy probe. All your phaco machines have vitrectomy probes. I use a posterior vitrectomy constellation, but you don't need that. All your phaco machines will have it. But look at the Purkinje image now. It's bang centered. You see that? Now, if you want to make it look aesthetic, a trick which I learned now, I've not done it at the disc space that much, is switch off the microscope light and use only the endoilluminator for doing the small pupillectomy. You'll get a class thing, and I'll try to see if I can show it to you also. But look at this patient here. Pre-op 636, post-op 66 N6. Because what you have done in this case is basically, you made it a pinhole, no doubt. He can see distance and near without glasses. So his multifocal problem is solved. Now I'll show you another interesting case, okay? I tell you what, to be honest with you people, we are doing a lot of keratoplasties in our center, about 120 a month, which is one of the highest globally if you ask. But now I started doing cases like these, which anyone will think of, let's do straight PK. I'm saying no. Can we manage them without keratoplasties? Now look at this case, okay? I've got 5 minutes left. So look at this patient. This patient came to me from Bangladesh. Look at the case, 109 HOA. Can you believe it? I asked him, what is the HOA before I operated? They said 109. I said, are you joking? I never seen a patient with 109 HOA. Remember, normal is 0.3, okay? 109, the highest till now, before this case I had operated was a 13 HOA. I said, 109. Man, that's crazy. So now look at the astigmatism, about 48 episodes of astigmatism, okay? So I said, listen, the surgeon who had operated had messed up the corneal suturing badly. So I thought, let me remove it. There is a traumatic cataract also present there. So now what I'm doing is, I'm doing a phaco, and now you see the fastest phaco in the world. Just watch. It happened so fast, I had to see it on slow motion later on while I was editing my video. Look at that. I've done my hydrodissection. Now I'm going for my phaco, and you'll see that in a second, and gone. You know what happened? It came out of the wound. My wound opened up. My heart sank. Pop. Okay, I said, patient has come all the way, referred to me from Bangladesh. Man, I got to make this patient all right. So I said, okay, now nucleus has come out faster than I can imagine. Let me suture it up. Still leaking like crazy. I have an upper burner this time. Okay, my heart is sinking even more, by the way. I'm trying to avoid PK. You see how dumb I am. Thinking of the craziest things. Anyway, I put the 3-piece IOL inside. I always choose 3-piece IOL because suddenly I go into complication, I can convert to glued IOL. Okay? So in such cases, you'll be better off with a 3-piece IOL. At least for me, I feel it's always better off. Now anyway, I'm doing my photoreoplasty. 3 minutes left, but let's understand how to close up this case. Now important is, please understand, if this car is off-centered from the cornea center, I'm very easy for me to do. But here you notice it is really near the center. Understand my problem here, that's where the challenge I'm facing. So now, when I will do my pinhole, I have to keep it exactly bang on track. I have to miss the scar, and I have to see my Purkinje image also bang on track. Now I'm just saying, can I do it or not? Worst comes to us, if I didn't work, I knew I'm making a pinhole, later on I'll do a PK. And my pinhole will anyway solve the problems. But now look, I'm using my endolimeter, look at it, using the vitrectomy probe, I'm just making that slowly and carefully so that my Purkinje image there is just missing it. Now, in the night, I just, look, this is with the microscope light switched off. Okay, I'm using only an endometer. Now in the night, I didn't sleep. I was just hoping and praying this patient will see the next day. Post-operative, day 1, 6/12. Look at that. Now you look, I'll tell you something better what happened, okay? Look at this. The HOA, I had shown this to Jack Holiday, and look at my HOA from 109, within post-op day 3 went to 5. Because I had resutured the cornea properly, it went to 5, and the patient went to 6/6, N8, post-op day 3. So I just thought I'll show you this case, and let me see if I can just show you one thing more interesting. I'll show you another interesting, just a photograph because we don't have time. Okay, but it's important for you all to see this. This was a post-DALC. Look at the picture on the top. Done by us only post-DALC, but there's a scarring on the cornea. Okay? I said, listen, I'm not going to redo a DALC. I did a pinhole. See a pinhole? This is without the microscope light. This is how coaxial. Look at a 1 week post-op, 6/6, N6, without glasses. What is my message? Want all of you, please move to pinhole. You see a lot of advantages. You will be in the learning curve. Second, because when you master the game a bit, you will understand corneal scars, these cases which you normally would have sent for PK or something, you can manage very well with pinhole and make them all right. Thank you very much, ladies and gentlemen. Any questions, please free.
Any questions?
From Indonesia? Nice.
When to do the PUPILLOPLASTY post
No, after repair of the cornea.
How soon?
Very simple. When I'm repairing cornea, I fish all in one shot.
In my country, we wait until 3 months after
Why?
repair.
Patient remains blind for 3 months now.
Yeah.
Why? Tell me one reason why.
Because the repair of the cornea.
The answer is very simple in my question. I will first thing I'm telling you off record, I always say everything one shot. And it's not only for iris repair and IOL implantation, which is very easy. Even if I do retina or PDEC, I'm telling you I finish all in one shot. Because I don't want a patient come again and again for surgery. Look, unnecessarily getting a patient for surgery makes no sense. If I can do everything from retina to anterior segment, I'll finish all in one shot. That's my personal opinion. Okay?
Need to sign?
Thank you very much, everyone. Can you take an off? Because I think it's crossed the line.
Yeah. Thank you so much.